Hello everyone, Professor Veg here. Today we are going to talk about pathophysiology. In this lecture we will discuss the structural mechanics of disease, showing how a single disruption at the cellular level can affect the health of an entire global population. Please remember that you need to have a solid foundation in human anatomy and physiology in order to understand the concepts that we're going to talk about. Along with this lecture PowerPoint, please look at your key points that I provided in the module and fill out your study guide as you listen to this lecture. To understand disease, we first have to understand what balance is, which is homeostasis. Homeostasis basically represents the body's normal functional parameters. Think of it as a green light, where your vitals, like a blood pressure of 118/78 or a temperature of 37 degrees Celsius, are stable and optimal. Disease or pathos occur when this balance is lost and homeostasis goes awry, resulting in suffering. So while we're talking about this, we also have to look at the aging factor. As the body naturally deteriorates over time, its ability to maintain this balance independently decreases, making medical intervention a necessity. It is important to also differentiate between pathology and pathophysiology. Pathology focuses on structural changes, for example, the what of the disease, often identified through dissections or tissue sampling. But pathophysiology, on the other hand, is the cellular mechanics, the how of the disease. We track the step-by-step functional abnormalities, such as genetic mitosis errors or infections, that allow a disease to progress through the body. Etiology is the study of why a disease begins. So we talked about the how and the what, and etiology is the why. The causes generally fall into three categories. For example, you have pathogens like bacteria or viruses, genetics such as the 50-50 inheritance chance of Huntington's disease, and the environmental or lifestyle like stress and diet. So these are the three causes of disease. Most disease exists at a multifactorial intersection where several factors combine together. For instance, a family history of high blood pressure combined with a poor diet can lead to a clinical hypertension, right? So if you have, for example, even diabetes in your family, doesn't mean that you can't manage it. Now, if you are like if it's in your family and then at the same time you have a poor diet, that's just going to increase the chance of the disease. In a clinical setting, we use specific terms for disease origins. For example, nosocomial infections or HAIs, healthcare acquired infections. These are acquired within a healthcare environment, often due to non-sterile procedures. Then we have iatrogenic conditions. These are treatment-induced, such as a patient developing secondary diabetes due to chemotherapy. Finally, we have idiopathic diseases, are those with no origin. The prefix idio literally means idiot, unknown, right? For example, as seen in primary hypertension. When assessing a patient, we look for clinical manifestations, right? We look for signs and symptoms. So what is the difference between a sign and a symptom? Signs are objective. They are things a practitioner can see, measure, and verify, like a measured fever or a visible bone fracture, right? Symptoms are subjective. These are internal feelings reported strictly by the patient, such as pain or nausea. Because symptoms are variable and influenced by culture or age, we often use tools like the 1 to 10 severity scale to quantify them. Because remember, in healthcare, we tend to quantify everything. We want to verify what the patient is saying so we can provide the care they need. We also categorize disease by its spatial scope and activity cycle. For example, a location condition is confined to one area. A local condition, is confined to one area, like a fracture, while a systemic condition has a body-wide impact, such as sepsis. So it's basically systemic. It just spreads everywhere, as you can see in the picture. Regarding activity, a disease may be asymptomatic, meaning it's active but not yet showing signs, in remission, present but not manifesting, or an exacerbation, which is a flare-up where symptoms become significantly worse. For example, when patients have heart failure, they say they're managing it well, they're at home, but then all of a sudden they have an exacerbation of that heart failure. So they end up coming to the hospital, presenting to the ER with, more significant signs and symptoms. This graph illustrates how diseases behave over time. An acute condition, like the seasonal flu, for example, has a rapid onset and short duration. Chronic conditions such as type 1 diabetes are persistent and often lifelong. Some diseases are subacute, falling in the middle, while others are insidious. Insidious diseases have a very gradual onset, driven by cumulative effects. Often they remain hidden until they are well advanced. The clinical workflow follows 3 logical steps. First is the information gathering, which combines lab tests with the patient's history. Notably, this relies heavily on patient honesty. Second is the diagnosis, where we apply an accurate clinical label to what we gathered. Finally, we provide a prognosis, which is a statistical forecast of potential outcomes and treatment plans. Remember, a prognosis is a forecast, never a guarantee of recovery. Now let's talk about epidemiology. We track 2 main metrics, morbidity and mortality. What is the difference between these two? Morbidity is the disease rate within a population. For example, tracking obesity levels. Mortality is the death rate. It is important to note that a higher morbidity often drives mortality. For instance, higher rates of obesity inevitably will lead to elevated cardiovascular mortality. So they're different but connected. Think of these matrices using, for example, the faucet and tub analogy, right? Incidence is the faucet. It measures the rate of new occurrences, how fast the water is flowing in. Prevalence is the tub. It measures the total percentage of the population currently living with the diseases. So basically, you're measuring how full the tub is. While incidence tells us about the speed of the spread, prevalence tells us about the total burden on the population. We categorize the spread of disease by geographic reach. For example, an endemic disease is isolated to a specific regular area. An epidemic sees a widespread expansion throughout the country or region. A pandemic occurs when a disease crosses continents and becomes a worldwide problem, as we saw with the global HIV and AIDS crisis, or even during COVID. We labeled it a pandemic because it was across continents and throughout the globe. Our goal in healthcare is basically to move down this pyramid of prevention. The tertiary tier is reactive, focusing on treatment, identified diseases through surgery or pharmaceuticals. The secondary tier focuses on detection, like mammograms, like screenings, to catch these issues early. The base tier, or prevention, primary prevention, is proactive and daily action, like wearing helmets or maintaining a proper diet to prevent illness from ever occurring. So it's important to understand and recognize the different tiers of prevention. This unified framework basically shows a true clinical mastery, requiring looking through 4 lenses simultaneously. You have the cellular core, the pathophysiology, the patient lens, for example, the signs and symptoms, the population lens, for example, epidemiology, and the societal shield, which is our prevention. A failure at the cellular level ultimately dictates the health of the entire global population, as we mentioned when we started this lecture. Currently, we in a paradigm shift. We are in a paradigm shift. So basically, medicine is slowly moving away from the quick fix reactive treatments towards the more proactive primary prevention. As future healthcare professionals, your primary mandate, your goal should be to educate and model these behaviors. You are on the front lines of leading the shift toward a future where patients take accountability for their health. And that is it for this lesson. And remember, do not self-diagnose yourself.